to The Lisa Show, where we take a good look at life. I'm not sure anyone knows this, but my very first radio show was co-hosted, co-created with my guest, Dr. Christopher Valentine, my big brother. Now, don't laugh. I'm being professional. Growing up in the 80s, I don't remember how it started, but we began a radio show with a small microphone and an old tape recorder and recorded the local news, even though we weren't bilingual at the time. Now you are bilingual.
See,
as for Dad. We'd record it every Christmas Eve or so, and it had the news, it had a cast of zany characters, and even a cooking show. And who would have thought, years later, I would have a podcast of my own? Well, I mean, we wouldn't even have known what a podcast was back then. And you would disappoint our audience by becoming a doctor.
Sorry.
And going to medical school. It's okay. Such a disappointment. Welcome, Dr. Valentine.
Well, thank you. Thanks for having me. It's been a long time coming.
Yes, it has. I do want to point out one thing. That our favorite segment, I should mention, was our cooking show with Penelope and Charlie.
Penelope Gordon.
Penelope Gordon. I was sort of a Julia Childs type character, and you were my mischievous son that ruined every recipe.
Yes.
It was really a comedy duo for the ages.
Just pure chaos.
Pure chaos. You just ruined everything I would try to cook.
It was awesome.
It was great. And we kind of excluded the other siblings, if I remember.
Well,
correctly.
Yeah, Gina would try to kind of get in on it, but we were not really good older siblings to her sometimes.
We weren't. We've since made up for it, though.
Yeah, I think so.
But at the time, we didn't have time for that.
But I think the trauma we imposed really kind of shaped the mature person that she is today.
I do, too. So you're welcome, Gina. You are also famously the last of the siblings to make it on the podcast.
No, I've been on the podcast. I was on the radio show once before.
That's what I'm saying.
Yeah, sorry about that.
No, I'm sorry. I'm really sorry. I guess I'm just saying that I'm saving the best for last, but don't tell anybody else, especially Gina.
Okay, it'll be ours.
Okay, thanks. Now, something that I appreciate about you is that you're very studious and that you study a lot, you read a lot, and you can disseminate a lot of information in layman's terms.
So you're saying I talk a lot is what you're saying?
No, I'm saying that you dumb it down for us groundlings.
Well, thanks. I appreciate it. Well, it's an important part, I think, in clinical practice. And I don't know if I want to use the term dumb it down because, I mean, that just kind of makes it sound like, but
you know what I mean.
I know what you mean. I know the spirit of what you're saying. People are not really interested in how smart you are. They are interested in what you have to offer them and that you care about them.
That's so true.
And I think a lot of times within medicine, we do a disservice to our patients when we use a lot of lingo, either, and many times unintentionally.
Sure.
In trying to explain what's going on with their health.
Yeah, and it's such a topic that everyone is concerned about. Yeah. It's universal, and it feels overwhelming, and healthcare especially feels overwhelming now. And I thought, this is so great that I trust your advice, right? And I've texted you a lot, like pictures of my kids' cuts and injuries, like, do they need stitches?
Yes, stitches, no stitches.
Or like, I'll be like, look at this rash. How concerned should I be about this on a scale from 1 to 10? Or do we need to go to the ER? I love that you always, number one, give the big brother smart aleck response, which is, oh my gosh, your arm's going to fall off in 30 seconds, which is something you texted to me once. Do you remember that?
No, but I don't. But I don't doubt that I did that.
Or sometimes I'll text you and you'll be like, "No, anything but that." That's funny. And then you give me the right information.
Yes.
So,
it's because
that's a talent.
Because I'll just tell you, in clinic with real patients, you can't do that very often. Okay, I will say I had some patients I'd seen for many years. I could joke around with a little bit, but I had some patients I'd seen for like 15 years. But 99.9%, you don't have that chance. So it's
no
like,
one wants a jokey doctor.
And I think I've texted you from time to time saying, oh man, I was in a meeting or I was in, and it's like, and I had this, like this was the perfect quip, but it was completely inappropriate. So you're kind of my inappropriate advice sink.
Thank you.
It's like, I got to call, okay, I got to write this down.
This is going to kill for Lisa.
So, yeah.
It's good that we can provide that service to each other.
True.
I'm sure that you get sick of family and friends like just asking you medical questions.
Actually not really.
Oh,
I don't really. I mean,
honestly?
No, honestly, I feel like, hey, this is what I signed up for. This is what I am doing, and this is, in medicine, to a certain degree, yes, it's a job, but really, it's a career and it's a calling, and that kind of encompasses a lot of your entire life. And I think everyone kind of comes at it from a slightly different, perspective. But within family, friends, neighborhood, within our church congregation, I try to just say, no, this is what you do within an appropriate scope.
I love that your outlook on it is so service-minded.
Yeah, no, absolutely.
You're such a great guy.
Well,
thanks for being here.
I don't say. I know that all sounded so high-minded and everything.
No, it didn't. I'm not making fun of you. I promise.
But no, I know you're not. But I'm just saying. But what I'm saying is that like I made a decision that okay, if I do kind of bristle a little bit when, oh hey, my friend's brother-in-law's sister wants to ask you a question. And it's just like, well, okay, that. But for everyone, it's just. We all have our ways that I just see this as like, this is my way I can serve or show love.
I love that. And so I want to capitalize on that and have your knowledge and experience benefit the Lisa Show listener and podcast, if you don't mind.
Sure.
And first of all, I feel like we need a disclaimer. Do we need one? Can you make one up?
Well, what are you saying? Like these comments have not been evaluated by the FDA, by CMS, or by any regulatory agency, and it should not be interpreted as medical advice. Please consult with your own medical professional for the actual. Well, are you going to be asking me like a lot of really specific questions?
I'm like, you're so quick. That's exactly what I wanted. Oh, welcome to Basic Care for You and Your Family with Dr. Valentine. Okay, I really do want to ask like some general questions that I feel that we get a lot for the show. Mm-hmm. Whenever we have like a pediatrician on or a family practitioner, when we used to have a different format.
Sure.
We would just answer like, hey, what's going on now and how's it doing? And with the podcast, I feel like this is an opportunity to have an overall just sort of refresher on like basic care.
Okay.
That a lot of people don't know. And you and I have had these conversations and they've been extremely helpful to me and my family, honestly. So I'm going to dive in. Okay, it's cold and flu and COVID and RSV season.
Yes.
and everyone's like, wait, what? And like our sister Amanda just had a baby, and so we're like, don't go anywhere or touch anything or breathe or do anything because we don't want that baby to get sick.
And that was our policy as well. I mean, as your listeners may or may not know, I'm married to a pediatric infectious disease specialist. Which
is so great.
Yes, I'll tell you, it makes for some really interesting pillow talk. I'll tell you.
I'm sure.
She, we have 4 kids. She was in general pediatrics for many years and went back and is doing some subspecialty training right now. But with all of our kids, we just had a general policy, and like I said, this is again disclaimer. This is what 2 doctors do. We would not take our newborns out of the house really for like about 6 weeks.
Yeah.
We would, with very few exceptions, I think there were a couple times where like we maybe went to a small family event before the 6 weeks, but certainly within those first few weeks, we're just locking it down because we're just so accustomed to seeing the effects of, like you mentioned, RSV, respiratory syncytial virus on kids, and seeing a lot of the devastation and real morbidity that would come about because of that. So that was what we did. So, like I said, your mileage may vary, but that was our policy.
And I stuck to that policy. And if you'll remember, my youngest, Margaret, got RSV and had to be hospitalized.
Right.
And I know exactly how she got it. She got it from her siblings.
Yeah.
Hugh, who was 2 years old, just kept kissing her.
Yes.
And I'd say, don't kiss her. She's so cute. I know, and she's new, but he had a big snotty nose. And
and that's what RSV is for everybody else. For RSV, for all I know, I had RSV a couple of weeks ago. I don't really know. But it's just, as far as everybody else is concerned, it's just, common cold.
Okay, so this is my question. Yeah. We know that this is everywhere, and we've been told on major news services, hey, this season is going to be particularly bad for all of these. So my question is how worried should we be, and what should we do for basic family care just to when they say take precautions, what does that mean?
Well, unfortunately, we don't have an immunization against RSV. We do against the flu, as I think everybody is aware. And I know that there's historically, for some reason, I get a lot of resistance. When I was in clinical practice, a lot of resistance in getting the flu shot. But I would say that, just to answer your question, get a flu shot. I think that COVID has really caught a lot of the attention. But the fact is that tens of thousands of people were dying every year from just regular influenza A. And this year could shape up to be worse, the worst year in well over a decade, at least since like 2013. It's hard to say really quite yet, but all I know is that when I look at the CDC projections and the current cases, I mean, there've already been, like, for example, there have already been about well over 2,000 deaths from flu. And I think we've become numb to numbers like that. It's just like 2,000. What are you talking about? Like we had a million people die from COVID.
I know. Isn't it weird how we get used to it?
Yeah, we are kind of accustomed to it. And yes, these individuals who are succumbing to the disease, typically have a lot of other chronic illnesses and whatnot. But that is just this very much is the same situation that we had with with COVID, which is it's not just about us and the health of ourselves or our children, who generally are going to be able to do, unless they're infants like we were talking about, are going to do reasonably well. It's the people around us. It's about trying to keep those who are the most vulnerable around us from getting sick.
Yeah. And it becoming fatal.
Yes. Yeah. And so in addition to the flu, getting your annual flu shot, and it's not too late. I know that we're already in the thick of it, but it's never it's really never too late. Getting a booster for COVID-19, obviously. Just a couple of months ago, they came out with the newer variant type that is specific. That's going to be much more effective at protecting you against disease.
Okay. And then wash your hands.
And all of the other things. So
don't be gross.
Universal precautions and things like that. Now, I mean, yes, washing hands and just being aware of what you're touching and all the rest of that. I mean, I think everyone's kind of heard a lot about that. Now, I don't know, do you want to ask about masking and what our responsibilities are there and what we should do?
Yeah.
I mean, because that's still kind of controversial. I mean, I think that there is benefit in certain circumstances. If you go to most clinics and hospitals these days, everyone's still masked up.
Yeah, so, I had made an appointment, and there were instructions for me to wear a mask there and things. And I feel like that's pretty standard across the country.
Yeah, for the most part. I mean, I've seen some variability from clinic to clinic because in my current position, I kind of go around and I visit different doctors' offices. But I would say, use your best judgment. If you have any doubts that you yourself are sick, then I think it's just being, a good citizen to stay masked up, and just not giving. I mean, just don't give healthcare people grief if you are going to a healthcare facility.
Nice.
Just be nice. It's just like they're doing the best they can, and they've been through just a very difficult couple of years. So I just would just say, please just kind of think about.
I forgot about that.
From. Yeah.
Not COVID. I didn't forget about that, but I just forgot how intense it was because I'm not in that field for healthcare professionals.
Terribly traumatic for many people.
Yeah, I'm sorry.
I'm a bundle of fun here. This isn't what you wanted.
This is not the local news, but this is helpful. And Whereas before was silly.
Yes.
This is actually helpful, and I appreciate it. This is the question that a lot of moms and dads ask each other, on the street or on the phone, and they text each other like, how do I know when I need to take them in? And how do I know when I just need to keep them home? And I know this is a really difficult question, but I ask you this a lot. How do I know when just to let the cold or the flu, or I don't know what it is, maybe it's COVID, who knows, or just do its thing? And when do I need to take my kid to the doctor or make an appointment?
Sure. Well, I think it is very age dependent. I think kind of going off of what we were talking about before, with small babies, when they are having difficulty breathing, that is really where
you just take them in.
Where you want to take them in. And so, okay, well, what does that mean they have difficulty breathing? I mean, all these, toddlers just, a couple of our kids, I swear they just were just snotty for like a year straight,
Right.
It's just, and it's just.
The bubbles.
And it's
so gross.
And you're constantly just trying to, kind of
wipe
clear
their face,
them out. Everything.
They don't want to. Yeah.
Well, and the thing that the clinical sign that we're looking for is something that we call retractions. So that today's word is retractions.
Thank you.
And retractions are when babies or toddlers are breathing so hard that they are sucking up between their ribs, underneath their ribs, maybe above their clavicles, and you're seeing some what we call supraclavicular retractions, which is really that space kind of, between your neck there. So if your kids are really consistently having to really work and there's an increased work of breathing like that, that would be a good sign to go in. Certainly if they are becoming what we call cyanotic, that's our second word for the day,
wow.
See, I was talking about like not using lingo, but what I'm trying to do is we're educating. We're going to learn some words. So cyanotic, which means they are looking a little bit, as you can imagine, a little bit blue, a little bit gray. So if you're seeing their lips turning a little bit gray, I mean, sometimes during fits of crying and tantrums, all of our kids have done that. Where in fact, I have this great picture of one of my kids just really upset about something, just totally blue lips, but that will resolve relatively quickly. But if it's looking consistently that way, that would be another good reason to take your kid in.
One of Christopher, my late husband, his brothers would have a tantrum or get so mad at his siblings and that he would regularly pass out.
That happens. I've had a few,
and they still tease him about it today. And
it happens.
And I am laughing, but maybe I shouldn't be. Is that serious?
No, breath holding spells are not serious. I mean, you want to.
You got to know the difference between.
I don't want to tell anyone not to. If your kid passes out, I'm not going to tell anyone not to take their kid in to be evaluated, because you want to make sure that it's not something else, that they're not having seizures or anything else like that.
Course.
So with that disclaimer, I would say that it is a common thing sometimes for those breath holding spells for kids.
Well, because you have some kids who do that.
Completely, they're just so beside themselves, and so I don't know. Did any of your kids do that?
Once. Yeah.
Okay.
Yeah, once, and it freaked me out. Yeah. And I'm sure I called you.
Yeah.
Like, do I need to take them in or whatever? Because they were so mad.
I can't remember if it was you or Gina.
But it was me. Of course it was me and my kids.
Well, that's funny. So the other thing, I'll just say from a clinical standpoint, we're looking at when we see little kids like breathing greater than 60 times a minute. But it's kind of hard to count breaths. But I mean, that's another guide. If you have a newborn that's breathing that quickly, that would be a good reason to take them in. And any kid, a baby under 3 months of age, if they have any kind of fever, if they have any fever, they really do need to be evaluated.
Okay, but what about for older kids and a fever?
Well, older kids in a fever, there's kind of definitely more of a wait and see approach. You want to kind of check in. In this forum, I want to say check in with your pediatrician, with your family medicine doc. But for the most part, routine fevers do not require a visit to the doctor. I mean, in the absence of any other really worrisome symptoms themselves. But make sure that you're reviewing a lot of these systemic signs with your doctor, including those respiratory signs. Very occasionally there could be concerns about urinary tract issues that are not as common, but can also cause fever as well. You should have Marilyn come on. She could.
I know. I've had Marilyn on before.
More.
I know. Marilyn could scare us a lot better because she's in infectious diseases. Here's the thing about Marilyn. She's real busy right now.
That's true.
It's really hard.
She's on service right now.
I know.
Yes.
I'm not saying that I tried to call her first. I'm not. Don't put those words in my mouth. I'm saying I'm so glad you're here. How do you feel about cold medicine and cough medicine over the counter when we feel crummy? And what works best?
Okay, well, to kind of go back to the conversation about kids, a lot of those cough and cold medicines, they just, to be honest, there's just not a lot of really good evidence. And to be honest, I haven't really looked for for a few years. But a lot of the latest evidence that I saw from just a few years ago just shows that it's difficult to really show that a lot of these decongestants and cough suppressants are really doing a lot to really improve quality of life or the duration of illness or any of those other kinds of things. And certainly with certain medications like dextromethorphan, which is a cough suppressant, or diphenhydramine, which is an antihistamine, you really do have to be extremely careful with younger kids, and some of those really should be avoided in a lot of the smaller children. So with our kids, to tell you the truth, we really didn't give our kids cough and cold medicine that much until they were a bit older, until they were like about 7 or 8 years old. What we did do, I'm not really answering your question, but
no,
I'm
You're getting to it.
I will say what we did do with our kids was we did nasal saline irrigations and suction, which they hated. They saw that bulb, they were like, no. But
it's like blowing their nose for them.
It is, because what you're doing is, you really have to be aggressive. I hate to say it.
Two doctors aggressively suctioning out their kids.
But you have to inject in some of the saline first, and then
loosen the mucus.
You just go and we got really good at just squirt it in and then suction it out, squirt it in, suction it out, and just to try to clear the symptoms, because they're
miserable.
They're just mucus machines, and just clearing. It's amazing how much.
Oh, gross.
So but
okay.
But that was just simply much more effective.
Okay.
And that's what they're going to do for you in the emergency room or in urgent care anyway.
Yeah. They have those little tiny tubes that they stick down to the back of your throat to suction out.
Yes. Yep.
I know how to use those.
Those are good. Those are actually more effective. To do it effectively, you got to know what you're doing. Yeah.
Yeah. What about as an adult? What do you take when you get a cold or the flu?
I will take some guaifenesin and dextromethorphan sometimes. Guaifenesin is branded as like Mucinex and the like, and that's basically, it's an expectorant and it just loosens the mucus. I will say, for it to work effectively, you have to be well hydrated, which often we're not when we're sick. And so if you're taking that with and you're taking that with a lot of fluid, it's just going to kind of loosen things up. The dextromethorphan, it's a cough suppressant. I just take that just so I can sleep. And so those are really the two main ones that I'll take. I'll occasionally take like a NyQuil type, just to be able to sleep. But I personally, this is just me, just personally,
just you.
During the day for like decongestants, I don't like decongestants. But that's just me. Some people, decongestants, otherwise they can't function. For me, it just makes me irritable. It just makes me I don't know. And so I just avoid those personally. But your mileage may vary.
Okay. Like that. Okay, this one we talk about a lot, and I've gotten mixed reviews with friends, with family, and with you at different times.
Okay.
Can you guess what it is? Supplements. What should I be taking? What's the deal?
Oh, boy.
And I know that this is a really extensive question, and I would just love, how do you feel today? What do you think is a general rule? Mm-hmm. How do you feel?
I think that the supplement industry makes a lot of money, and that they do so because they are able to effectively interface, communicate, and make people feel that there is something lacking that they need to add to their lives. And do I think that there are maybe some corners here and there where our diet is inadequate? I think here and there, yes. So let me kind of just start with maybe a couple of the exceptions. I think, certainly you need to see a doctor if you're iron deficient. Iron deficiency is something that can be a little insidious for certain people, particularly if they have certain dietary restrictions and things like that. Mm-hmm. Vitamin D, I kind of go back and forth on vitamin D because, what we're setting as a normal level of vitamin D, I think is it could arguably be maybe we're setting the bar a little bit high because, according to some of the more recent studies, like, I don't know, I've heard different people say like up to a third of people are vitamin D deficient and it's contributing to a lot of issues. So I'm kind of, I think the jury's out a little bit on vitamin D, and I kind of lean towards saying, it can't hurt. It can't hurt to supplement that. I think for much older adults, oftentimes vitamin B12 deficiency, cyanocobalamin is a major issue for them as it relates to their blood production as well as nerve function and things like that. So I'm just telling you what the things that I actually saw in clinical practice. Those would probably be like
things that people needed.
Those are the things that people actually needed, like the top 3 things. But, there's like a lot of these other ones that you learn in medical school that are just like these, scurvy and pellagra and all these other things. It's just like, you just never see them, because we get enough of these vitamins in our regular diets. So what about all these other things? Do I need to take like a Mega Man, vitamin or Centrum or anything else like that? I think for most people, if you're getting a reasonably balanced diet, it's just making your urine more expensive, and maybe kind of a bright color, and So I'll just tell you, like this is kind of going beyond the scope because this is getting into in the doctor-patient relationship. I don't like to poo-poo what people are doing. You know what I'm saying? Because at first I was, I'd say, oh, well, this is clearly not based in evidence. And, because there's really been a huge push over the last 30 years in Western medicine to say, hey, look, if we're going to recommend something, let's find some evidence that it actually works. If, whether it's a surgical intervention or some kind of cancer treatment or whatever. It's just like, let's not make recommendations based on what quote unquote makes sense based on the biochemistry we see, but is it actually saving lives? I mean, that seems like a really simple question.
It does.
And that's a huge part of my current job in working with physicians to try to promote evidence-based medicine. But I apply the same thing to vitamin supplements like you're talking about. So that said, when patients ask me about it, I want to just say, look, yes, these things certainly can, as the ads say, support a healthy immune system or support a favorable mental health profile or whatever it is that they're selling. So I would just say, look, if these are this is a domain in which it is enabling you and empowering you as an individual to feel like you're taking control over your health and over your life, then I say, go for it. That said, I did have a few patients that were literally spending hundreds of dollars a month on a lot of supplements of dubious, quality and or efficacy at the expense of evidence-based medications that they needed to be on in order to protect and reduce their cardiovascular risk, manage their diabetes, because they wanted to take a quote-unquote natural approach. I'm doing air quotes here.
You can't hear.
Those
they're not very loud.
Oh, this is a podcast. Okay, and so it's really a balance in just saying, look, if you take it and it makes you feel better, I'm not going to get in an argument over what a placebo effect is and all of the rest of that, but I would just say make sure that we're looking at the fundamentals and don't look at any of these supplements as being a quick fix or some sort of way to avoid some real evidence-based and modern solutions that we have to treating very real issues. So again, emphasis on the term supplement. That's sometimes a supplement for some people becomes a replacement. And that's where a lot of my concerns are.
Okay, well said. What What do you wish more people knew about or believed with your experience in talking to patients as a doctor? This is like, if I had one wish.
Like if I could get people to
believe you on one thing.
That increasing fruits and vegetables in their diet does seem to have some kind of protective effect against certain cancers and cardiovascular disease and general inflammation in the body that is more than just, I don't know. I feel like it's a message that has just become so old, like eat your fruits and vegetables, and that it's not taken as seriously because it's just like it's not new. It's not like we've been saying this for years, but
it's like drink more water.
Yes, and
exercise.
That all exercise that would
get 8 hours of sleep.
Like all of these things,
they're not very flashy.
They're not, but here's the other thing I'm going to go off on. It's just that
I knew you would get sparked by this.
Okay, well, your question was like, what do I wish people knew?
Or believed
that we have evidence for things that seem to actually work, and a lot of those things are relatively simple and basic, and because of that, I think that they're often dismissed. So when we look at just the health of populations, I'm just going to get this. I'll try not to get too technical here.
This is why I asked you to come on.
Well,
because
right now, I mean, I won't get into like a lot of what I do, but right now, a lot of what my responsibility is not just taking care of individual patients, but in my position, I'm trying to help manage the health of tens of thousands of patients through a care delivery organization by working with physicians in order to promote, like I was saying, evidence-based practices and ensuring that patients are getting preventative care. And I don't want to say, well, it's not disappointing, but it is a little disheartening for all the work that we do as physicians. Really, the effect that we have is probably, I don't know, like, I can't remember what the figure was, but it's like 10 to 15% of actual patient outcomes. Oh. Like it's like we're kind of turning the dial like just on a little tiny bit, which for all the many years of practice I was in, I just kind of feel like,
you're trying so hard.
I'm trying so hard, but I'm really only doing this much. Well, so what's all the rest of it? What's all the rest of it? The rest of it is diet. The rest of it is physical activity, genetics, and the zip code you're born in.
Wow.
It's basically what we refer to as our social determinants of health, which have to do with the environment in which we grew up, both psychologically, both behaviorally, as well as from a health standpoint, the exposures that we had as children or the exposures we have as adults. And the circumstances under which we live our lives, getting back to, again, diet and, like you mentioned, sleep, which I think is highly underrated as well, and our adherence to different kinds of healthcare practices. So I think your original question about what do I wish patients knew is just that all of those things really, in the end, are probably more. I mean, that's really going to have more to do with what our outcomes are going to be than the kinds of medications that physicians will put people on. And that's not to say that there isn't some value. Obviously, there's a lot of value to, managing diabetes and cardiovascular disease.
Course.
And there are great treatments out there. Like, for example, I wish I could impress on more patients how effective a certain class of medications called statins are. There's been some criticism of statins because they do cause some side effects in some people, but statin medications which lower cholesterol, which is often genetically determined. It's not just like, it's just from eating a lot of cheeseburgers or something like that. It's like, no, some of us are just genetically more talented in our ability to make cholesterol because as mammals, we make cholesterol very effectively, and it is very necessary for our metabolism. But in our world of abundance and whatnot, it also increases our risk under certain circumstances for a heart attack and stroke. But there are medications that can bring that under the right kind of control, and I wish more people understood that how effective those can be for the right people.
Wow.
Yeah.
This is why it's so valuable to talk about it, right? To think, oh, there's some information that maybe I don't know that I need to know that is critical for my health.
Yes.
And we got to talk about it.
Yeah, I mostly focus on like older adults and Medicare aged adults. There's a lot that a lot of your listeners, should certainly review in terms of what they need for their particular age categories, and that might be a little bit more than we have time to get into right now. But there's a lot that adults as they get closer to age 65 really need to get on top of in order to be able to anticipate some of those issues as they come up.
Like what?
Well, I'm just thinking like colon cancer when you're age 50. Actually, the new recommendation is age 45. Yeah. And making sure that you're screening for diabetes, that you are screening for osteoporosis if you have certain risk factors, and screening for, there's a lot.
Yeah.
Vascular disease, retinal disease if you're diabetic. It's just that everybody has different risk factors, and it's really not one size fits all. And I would say, and I'm biased because my background is in family medicine, but I will say one of the best things that you can do is just establish a regular relationship with a primary care physician, even if you're not.
That's what I was going to ask you, because it seems overwhelming to come in and say, hey, I think I need this test and this and that. So for people who want to be very, prepared and healthy, then you suggest establishing a relationship with their over how many years? Like, is it too late to start?
No,
when?
It's never too late. It's just I frequently saw people who I just wish I had the opportunity to see them, 5-10 years ago. But
really,
yeah, because there are ways that we can try to head some of these things off. I think that many times people with diabetes, for example, live with diabetes for years, at least months in some cases before they're actually diagnosed, and so having that relationship, having that regular check-in, that's just going to be a way that you can be more proactive again and just kind of feeling like you're taking control of your health.
Throughout your career, you've been able to meet lots of different kinds of people and really work in the medical field in a lot of different capacities. For health insurance, for families, for individuals, hospice, nursing homes. You really have had quite a career and met a lot of people. In that time, has it changed the way that you sort of see relationships with people? Has it changed the way that you see life?
Yes. Oh, for sure.
How?
Actually, I think that I have a lot more. I've definitely developed a lot more empathy about people's individual backgrounds and where they came from. When I was first in private practice, and when I was working in the nursery, you remember, for many years, and taking care of newborns and sick newborns, and just really seeing the backgrounds that people where they were coming from, and a lot of these other factors, kind of like I was alluding to before, these social determinants of health, and kind of seeing how it's a lot of the things that we take for granted in terms of our access to healthcare and our ability to be able to organize a lot of what are often very complex requirements in order to be able to fulfill the things that are being recommended to us, are just really difficult for a lot of people for a lot of different reasons. Some of them financial, some of them social, and some of them environmental and behavioral. And I've had just a great opportunity to really see that from a lot of different perspectives. And then from another perspective, being able to see how the healthcare system itself works, because I've been both on the practicing side, and then right now I'm on the care delivery side, which is to say that my focus is on trying to manage resources for large healthcare organizations in order to make sure that we're using those resources effectively, and we're not just wasting a lot on care that doesn't have very good evidence and that is in many cases harmful. And because, practices are always changing, like they always say, when you graduate from med school, 10, 20 years later, half of that information that you learned is going to be incorrect or out of date. And the problem is you don't know which half. And so things are constantly changing. And so I see, I have a lot of, just lot more patience, I guess, in understanding the pressures that the different parties are under, whether it's the hospital or whether it's the healthcare organization, the insurance company, the patient and the physician, and the different pressures that they're under in order to be able to try to make the healthcare system work better. But it's still there's still fundamentally a lot of, the nicest way I could say it, there's still a lot of challenges in trying to get the right kind of alignment there. So I feel like I've had a unique opportunity to kind of be an ambassador between those different, those different pressures.
Right. And I feel that it has led you to be very compassionate, very empathetic, very helpful.
Yeah, well, everyone's doing the best they can. And it's just like I mentioned before, there's just a lot of burnout amongst physicians in the medical community in general. I don't know how much mainstream press attention that really gets, but there are a lot of physicians, particularly in the hospitals, in emergency rooms, in primary care offices, who are just leaving medicine. They're just retiring. They're going and seeking out other careers, or and amongst nursing, there's also a crisis amongst nursing. It's hard to get staffing for nursing because they have been just so abused for so long, and particularly over the last couple of years. And it's been very difficult. There's been a lot of what we refer to as moral injury in trying to provide the best care possible, but not having the resources always to be able to provide that. Especially when you have overcrowded ICUs and you are trying to manage patients that don't have really the same alignment as far as what those healthcare goals are and preventative measures. I think I'll just leave it at that. And it's created a bit of a crisis in the system because we don't have enough primary care physicians, and in many parts of the country, not enough nurses.
So what are we going to do?
Well, so what are we going to do?
I know. See, I get to ask questions like that, and then I can see in your eyes, your brain exploding. Like I have so many ideas, and I don't even know which thread to go down.
Well, I think a lot of it is cultural within our healthcare system. A lot of it has to do with aligning incentives the right way so that we're really providing the right kind of resources that are based on actual value. Like what are the actual outcomes like? Like, I mean,
does it work?
Like I was talking about, evidence-based care. It's just like we need to apply evidence to the way we design our systems, because the way our systems are designed are not based on, they were not let's just say they were not intentionally designed. When you get some kind of surprise bill from the hospital, or you have to get an authorization for something, or you only get in to go see your doctor for like 15 minutes, this was not an intentionally designed system. This was a system that just has kind of come together as a result of a lot of different circumstances over the years.
Yeah.
So to answer your question, we have to really ask about how some of those systems are designed, and who's making some of those decisions, and what sorts of resources that we have in place in order to support our caregivers.
Yeah,
that's very simple.
No, it is,
answer.
but it is powerful though to say we need to take care of our caregivers.
Yes.
Yes.
Yeah. No, it's the mental health. Mental health amongst caregivers has been low, and it's like I said, it's a complex problem. Yeah.
Well, I appreciate you taking the time, like I said in the beginning, of breaking down really complicated, intricate systems or ideas into a way that we can understand.
The Lisa Show is a production of BYU Radio. The show is hosted by Lisa Valentine Clark and produced by McKay Menden and Becca Hurley, with help from Tabitha Freitas, Michael Combs, Kaya Dibb, and Brooke Soldani. Our music and post-production team includes Sam Clausen and Josh Fouts. As we speak, we're working on our next series of The Lisa Show, which is going to be all about body image. However, in the meantime, if you haven't heard it yet, we hope you'll go and check out the Self-Care series, an amazing 11 episodes uncovering every aspect of self-care you could imagine. It's got something for everybody. And of course, we love to hear from you. Check us out on Instagram and Facebook. Send us a message. Tell us what you think of the show. We love your stories. We take every message to heart, and it means so much to us that you talk to us.